Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce Dr. Jay Resnick, DMD, MD. Dr. Reznick is a board certified by the American Board of Oral and Maxillofacial Surgery. Jay, thanks for being on the show here today.
Oh, thanks, Phil. My pleasure. Good to be here and talking to your listeners.
Now, I'm in Leawood, Kansas, and you're in sunny Southern California.
Sunny but cold.
Sunny but cold. Okay, yeah. So why don't you do a kind of a brief introduction on your education and just tell me a little bit about yourself so the listeners can kind of get to know you.
Okay. Well, I am as kind of a rarity among Southern Californians in that I was actually born and raised in Los Angeles. Went to undergrad up at Cal Berkeley and then returned back to L.A., did a year of research in the gastroenterology department at L.A. County USC Medical Center, then went off to dental school at Tufts Dental School. When I was there, got interested in oral surgery, did some research in the oral surgery department, and then got into residency at University of Southern California, LA County Hospital. And so I did my oral and maxillofacial surgery residency there. While I was in residency, one of my classmates had actually gone to medical school first with the thought of becoming an orthopedic surgeon, but he didn't get the grades that he thought that he needed to get into orthopedics, and his father happened to be an oral surgeon. So his dad said, well, why don't you go back to dental school and come into the practice? So he actually went from medical school and having done a year of internship back to become a dental student, and then was doing the oral surgery residency with me. And what struck me is that as we were rounding on patients and as we were talking about how to manage patients, his level of understanding was so much greater as a first-year resident in our program than even our chief residents. And it made me think that if I really want to be able to take the best care of my patients, I really want to understand what's going on with them medically, as well as be exposed to other disciplines besides oral surgery, it would be a good idea for me to go to medical school. So I completed my oral surgery residency and went from being a senior resident to being a first-year medical student at USC Medical Center, University of Southern California. And that was kind of a humbling experience because here I'd been a senior resident, chief resident, and a couple of months later, I'm at the bottom of the totem pole as a first-year medical student. And what it allowed me to see was something I think that really opened up my eyes, and that is that a lot of the residents that I had met when I was a resident in, let's say, general surgery or medicine, who were now faculty or fellows, some of them were really kind of malignant assholes. And I didn't realize it when I was a colleague with them, but when I was a medical student, I saw it. Having kind of been there and gone back, it made me realize that there's no reason to have an attitude. There's no reason to be full of yourself. That we're all there for the same purpose, to learn, to get educated, to get trained, to learn to take care of our patients. And some of the mind games and malignant teaching that I saw when I was a medical student, I realized that wasn't going to be the way that I was going to operate. And so it kind of changed my frame of mind as really to open up my eyes to becoming an educator that conveys my knowledge, conveys in my thoughts without being demeaning. And I think sometimes, especially in the surgical disciplines, that's kind of a rare thing. So I actually went through medical school after I was, when I was an oral surgeon. I finished oral surgery. And so while I was in medical school, I actually worked about 20 hours a week as an oral surgeon. And I was in a private practice part-time, and I was on staff at a couple hospitals. And I actually, while I was a medical student or on call, they would let me go to take care of patients in my private practice or at other hospitals who had oral surgery problems. So that was kind of interesting. And then when I did my general surgery residency, which you need to do to get licensed, I did a year of general surgery. I was able to negotiate to do the residency or internship the way I wanted, because I was actually in very high demand given my background. And so I was able to do some rotations as a general surgery intern that normally are reserved for second, third, and fourth year general surgery residents, such as plastic surgery and rotations like that. So when I was on anesthesia, they'd let me do a couple intubations and leave and go practice for a couple hours. If I was on call Friday night, I said I'd have to be out of the hospital by 7 a.m. to go to my office, and they would get me out. So it was actually a really good experience. I learned a lot. I worked hard. I was doing a general surgery residency and practicing part-time at the same time. So when I got out into practice, I'd actually had a couple of years head start on some of my colleagues. So that's kind of how I got to where it started in private practice, and it's sort of grown from there.
Well, great. That sounds like a long, tedious road, but I'm sure now that you're glad you did that and have moved on, since those teachings are probably invaluable. I thought 4 years of college and 4 years of dental school was enough, so... I took the easy out there, but I definitely respect people that can stick into it for the long haul.
I was in school till I was 34, so
yeah, I know.
It was nice to be finished.
Yeah, I completely agree. Now, tell me where you're spending most of your time now. I know you've got some maybe hospital affiliations, you've got some clinical time, are you doing some teaching? What's the bulk of your time spent, or break down a week or a month for me as far as where you're at and what kind of capacity you're practicing in?
Well, my practice has kind of gone through multiple revolutions and evolutions over the last 20 years. And when I started in practice, having gone through, medical school and general surgery, I had a pretty full scope oral and maxillofacial surgery practice for probably the first 10 years or so. Did a lot of trauma surgery, orthodontic surgery, TMJ surgery, a lot of pathology. So, my office is right across the street from the hospital on the campus. And I was probably in the hospital operating room about at least once a week, if not twice a week. And sometimes, at night, and I was taking call at a number of emergency rooms. And over the years, what happened was my practice changed. And about 10 years ago, I started getting really involved with teaching. I'd actually taught at USC Dental School part-time for a little bit when I first started out in practice, and did that for a couple of years and got a little frustrated with the fact that dental students don't really want to learn much, at least when it comes to oral surgery. They just wanted to get out of oral surgery so they could get their requirements done to graduate. And so I found it a little frustrating trying to teach the dental students, because it seemed like a very small percentage of them really actually wanted to be there. So I gave up on that for a while. But I got involved with education from the standpoint of speaking about implants and speaking at the hospitals and educating people that way. And about 10 years ago, I started getting involved with technologies of cone beam CT and CAD/CAM and guided implant surgery. And that took me on a little different course, spending a little more time speaking. And I also, about 7 years ago, started an educational website called onlineoralsurgery.com, which the way that started was with Dentaltown. I've been a moderator and provided CE on Dentaltown for, I think it's been about 12, 13 years now already. And the courses that I did were so popular that I was encouraged to start an educational website on my own, which we got going about 10 years ago. And we're providing content for the general dentist who is possibly in like a rural area where they don't have the opportunity to send to a surgeon. The closest surgeon's maybe 100 miles away, and they're booked a month in advance, and they've got a patient in their office that has an infected molar that they want to take out, and they didn't really get the proper training when they were in dental school. So we're providing that education to them and giving them the confidence and competence to be able to treat their patient. So I started doing more with online oral surgery, started doing more video courses, because everything on the website is basically a video course. It's not just PowerPoints. We're actually showing surgical video that we record in the office. And so as that's evolved, as my involvement with some of the companies that I've consulted for has grown, my practice has basically evolved into what we like to call as an oral surgery teeth and titanium practice. I do lots of wisdom teeth, a lot of extractions, a lot of bone grafting, and a lot of implants. And I do probably 99.9% of my implants by fully guided surgery. And what's happened, I'm not on call in any hospitals anymore. Don't really do a whole lot in the operating room anymore. And I'm actually only in my office 3 days a week because I'm so busy doing everything else that 3 days a week is about all the time I can spend in my office. So when I'm in the office, those 3 days, it's usually pretty crazy. And the other 2 days, I'm either working from home, editing videos or writing lectures or writing articles, or I'm on the road off lecturing somewhere. So that's kind of where my practice is at now, 3 days a week. I try to, I guess it's kind of, you would call it a boutique practice. We start about 8 o'clock in the morning, and we try to be done by 4 in the afternoon. I don't see a high volume of patients. We just take really good care of our patients, and our patients like coming to see us. I have a great staff. Get a lot done during the day, but it's not like I'm doing 18 sets of wisdom teeth on a Friday morning like I hear some people are doing. It's more like 6 or 8 on a really busy day, and usually a few implant cases and that type of thing too. So that's where my practice is these days.
Well, that sounds great. I know you've done the full gamut, and now you're kind of doing more just what you want, and some other teaching and training on the side. So that's there's definitely a need for that.
Well, I definitely enjoy the teaching and the speaking. It's a nice diversion from the practice. The practice, if all I did was go in the office every day and do the same thing every day over and over again, I think I'd be pretty bored. But I have a nice variety of traveling, lecturing. I enjoy working on the website and producing videos and putting new lectures and new educational venues together. So it's a nice balance and allows me to kind of enjoy life a little bit.
Yeah, that's good. That's important to do. Now, you said that you're doing all your implants guided. Why don't you walk me through what a consult, a workup, and a surgery and follow-up for you kind of looks like? I know that's different for everybody. Everybody's got different philosophies and protocols, and obviously you're using some cone beam and some technology, and kind of tie all that in how you like to do that, and how you found that that's really benefited yourself and the patients.
Sure. Okay. Well, first of all, for those who are listening who are not completely familiar with guided surgery, basically what guided surgery is using a cone beam or CT 3D-based image and software that allows you to essentially do virtual treatment planning on the computer, and then you translate that treatment plan into a surgical guide that is used with a specific surgery kit so that the implants are placed exactly to that plan within 1% of angulation and a couple hundred microns of variation, so that what you plan in the software on the patient is exactly what you get in the surgery for the patient. And the thing that is a little bit different about guided implant surgery is that when I was trained to do implants 20 years ago, we were taught, you basically look at a two-dimensional panoramic, you examine the patient, you maybe get some study models, you maybe do some type of guide to help you with your implant placement. But essentially you were flapping the area open, looking at the bone, and then placing the implants where the bone was. And as a result, probably 10% of the time, 15% of the time, the implants weren't exactly where you had planned to put them. They were a little bit off angle, a little bit off position, and sometimes they were very far off because you put the implant where the bone was. And so then when the patient went to their dentist to get restored, it was very difficult to finish the case and create a prosthesis. What guided implant surgery does is it turns things the other way around. And so what you're doing is you're starting with your final prosthetic plan, which you then bring into the cone beam image. And there's a couple different ways of doing that. So you're basically planning your implant placement and positioning based on the final restoration, whether it's a single tooth or a fixed bridge or even a removable prosthesis or a full arch prosthesis. So it's all completely based on the prosthesis. So you're starting with the end in mind. And what you do then is if in some of those areas where you want to place an implant, the bone is not adequate, it's not wide enough, it's not high enough, you know that ahead of time. So rather than getting in surgery and saying, okay, what do I do now? All the variables are known ahead of time and you plan for them. And so once you realize that, you need to augment the bone, you need to widen the ridge, you're aware of those issues ahead of time and you plan for it. So rather than placing the implant where the bone dictates, you're placing the implant where the prosthesis dictates and developing the site so that the implants are in the right place. Now, as far as how you get the planning data into the cone beam, it can either be done with a scanning template that has some type of radio-opaque pontic in it, or these days we use CAD-CAM technology where we're actually importing the CAD-CAM image into the cone beam image and using that for planning and actually for designing the surgical guide. And in many cases now, the guide can be printed from a 3D printer with complete digital workflow. And so it's really changed the game. So I do everything guided implant surgery. I don't freehand place implants. And I hear people say, well, guided implant surgery is for people that don't know what they're doing or they're new at placing implants. And my argument to them is that guided implant surgery raises the bar for all of us. It improves the efficiency, the accuracy of implant planning and implant placement, no matter what level you're at. And, as you become more advanced in implantology, what guided implant surgery technology allows you to do is to plan bigger cases and to be able to execute them more accurately and more efficiently. When I look at some of the things that I can do with guided implant surgery, and I can do them with a high degree of accuracy and success, there are things that I could maybe do, by the seat of my pants when I was doing it freehand. So it really does change the game. It kind of, allows you to think outside the box. It actually makes the box bigger. And so what we can do for our patients is definitely a lot more because of this technology. So in my practice, I'm an oral surgeon. So patients come to me specifically, generally for implant placement. Either we saw them already, we took out the tooth, we grafted the site, and now they're coming back to plan their implants, or they're coming in for a new implant consult. So the patients come in, and first people to see them are my team members. And so what we'll do is we will obtain a cone beam scan. And if the patient has a fairly clean mouth, not a whole lot of crown and bridge, then they'll obtain the scan just by itself. But if the patient has a lot of crown and bridge, a lot of metal in their mouth, that will cause a lot of artifact with the cone beam scan. And so my staff knows to look in their mouth, and if the patient has a lot of dental work, they scan them with a specific scanning template which is used then to fabricate the surgical guide. So they come in for the consult, and then I get the chart to review. In the meantime, my staff brings up the cone beam scan in the consultation room. And so when I go in, we talk to the patient, find out why they're there, what their expectations are, what their desires are as far as their treatment. Then we sit down, we examine them, we sit down, and we start talking about the possibilities. And we take a look at the cone beam scan, and we actually start planning the implant, start planning the case right in front of them on the screen. So the patient comes in, let's say, for replacement of their missing teeth 28, 29, and 30. And right up on the screen, I show them where the implants need to go and show them the difference between doing 3 individual implants with 3 individual crowns versus doing a 3-unit bridge on 2 implants. Or, if they need bone, if their ridge is narrow or the ridge is atrophic, they see that at the consultation. And so when I'm explaining to them, we can place implants here, but the ridge is kind of atrophic. We could maybe get in some 8-millimeter implants, but we like to get in longer implants. We'd like to really put in 11-millimeter implants. That's going to give us more long-term stability. So we would need to do some bone grafting, and we show them on the scan why. Or let's say we're doing an implant in the posterior maxilla, and the sinus is pneumatized and the ridge has become atrophic. We show them how this implant, if we placed it, was going to be projecting into the sinus, and of course, air doesn't hold an implant very well. And so when we explain to them what a sinus lift is, we can show them how it's done on the screen and show them why they need it. And the thing is, the patients get it. When you show them on a panoramic, or you show them on a flip chart, or you show them on some computer program that's not them, a lot of times patients don't see it. But when you show the patients on an actual image of their jaws, they understand. And so that's been great for patient education. It's also been great when it comes to case acceptance. It used to be that probably about 80% of the patients I saw for implant consult, would accept the case. And now it's more like 95. And so what we do is we present the case, and if the patient says, okay, let's do it, then what we'll do is we'll go ahead and we'll do an optical scan so we can merge that data with the cone beam data for finalizing the plan, B, for actually creating the surgical guide. So then the patient goes to the front desk, they talk to the implant coordinator, they select their surgery date, they put their 50% down, and at the end of the day or at lunchtime, I finalize the case, which takes about maybe 5 minutes, and upload the data to Germany to have a file created for the surgical guide. And the surgical guide is either produced either in Germany or in the U.S., or I actually have a 3D printer in my office, so I print out a lot of my own surgical guides. And we generally get the case back within a couple days, and we're ready to go and get the patient in for their surgery. So it's a really easy workflow. And the thing that I love about the cone beam system that I have is it's very intuitive, it's very easy. As soon as the cone beam scan comes up, the image comes up, we're able to start planning implants without having to go through a number of steps to get there. So the implant planning software is integrated into the cone beam software. And it's a very seamless, easy workflow with the patient. And then at the end of the morning or the end of the day, to finalize the plan and get it uploaded so that we can have the surgical guide made. So it's a very simple workflow. We get the guide back, and then, of course, we use the surgical guide for directing our implant placement. And when we use the guide, not only is it more accurate, but it's more efficient. So in the old days, if we were doing, let's say, a single implant, we would drill our first osteotomy. We would take a position pin and put it into the osteotomy and take a radiograph to see, make sure it was lined up right, make sure we weren't too close to the adjacent teeth, and the angulation was correct. And then we do the second osteotomy, and then we put the positioning pin back in and do the same thing. And then we drill our final osteotomy and then place the implant. And if we, let's say we're doing a 4 millimeter diameter by 11 millimeter long implant in our panoramic-based plan, we'd always have a narrower implant standing by, we'd have a wider implant standing by, we'd have a shorter implant standing by, we'd have a longer implant standing by, just in case we got in there and we had to modify things a bit. With guided implant surgery, we basically put the guide in, we take our osteotomy drills, and boom, 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 we're done drilling. The implant goes in, and we're done. And it's the exact implant that we plan to use because we used 3D planning to know exactly which fixture we're going to need. And so it really has, not only does it cut down on the time it takes to place the implant, and I'd say it's probably about a 50% reduction in time. It's also been really good for our implant inventory to not have to have, hundreds of implants in the pantry, but really we order the implants as we need them for each individual case. So it's really helped with cash flow in the office too. And so if we're doing a case with 3 implants, that used to be a 1-hour block in the office, and now with guided implant surgery, I'm doing that in 30 minutes. And if I have 6 implants to place, we're doing that within an hour. And so you can, start thinking, not only is this better for the patient because it's less surgical trauma, the surgery's quicker, they're going to have less swelling, less soreness, but if I can open up another hour in my schedule every day, that means I can either do 2 more sets of wisdom teeth or I can go home an hour earlier, which is really nice. So there's a lot of benefits from guided surgery.
Yeah, I think, guided surgery's definitely opened up more doors than it's closed. So I'm with you on that. Can you tell me exactly, which cone beam and which software and which CAD/CAM scanning and which 3D printer and what kind of labs you're using? Can you be very specific on those just so that people can get an idea of what equipment you like and how that compares with what they've seen? Yeah,
so the cone beam system I have is from Sirona. It's the Galileos. And I've had it actually in my practice for about 8 years. And I'm on my second machine. And what I liked about it was that it was very intuitive, very easy to use. A lot of the other machines that I looked at, when you look at the software that came with them, it was a little bit complicated, to say the least, to navigate through the scans, to manipulate the data. And then, of course, what you would have to do is then use a third-party implant planning software where you'd have to export the DICOM files out of the system. You'd then have to import them into another third-party planning software. You'd have to clean up scatter, and it would take a half hour before you could actually start planning your implants. And so if you were doing 1 or 2 implants or a straightforward case, that didn't make sense. It was just too much time, where the software that was with Galileos was very intuitive, very easy to use. You could basically just pick up your mouse and start working within a minute. And so it was really, really nice to work with and very intuitive, very easy to use. And at the same time, the implant planning software being integrated into the diagnostic software, again, was a huge time saver. So it basically made implant planning take less than 5 minutes instead of taking 30 minutes. And so that made it possible for me to think about doing guided implant surgery for every single case. And, when you talk about the simple cases, doctors tell me, if it's just, number 29 or number 30 and there's lots of bone, I just do it freehand. You don't need a guide. I would like to look at 100 of their cases in that situation and see how many of those implants were perfectly placed. Because especially if you're doing a single tooth implant, placement is really critical. It's got to be parallel to the adjacent teeth. It's got to be centered on the ridge. It's got to be right under where the prosthesis is going to go. It's got to be equally spaced mesiodistally between the adjacent teeth. And to try to do that freehand, no matter how good you are, no matter how experienced you are, is not an easy task. And so 10 to 15% of the time, you're going to be a little bit off. And if you're doing a few hundred implants a year, then that's a significant number. As far as the CAD-CAM, I have CEREC. And I originally got CEREC so I could integrate it with my Galileos. And, at the time when I got it, it was the only system that integrated CAD-CAM and cone beam. And now there's some other systems on the market that do something similar. But you got to remember that CEREC's been around for 31 years now. Galileos has been around for like 8 years. I actually had the first one west of the Mississippi that wasn't in a dental school. Is that these two systems are made by the same company, and so they work together extremely well. Whereas with some of the other solutions where you've got one company making the cone beam, another company making the CAD-CAM, the integration is not as smooth. And so I really like the CEREC Galileos integration, and I used it at first just for doing implant planning. Then as my ability to work with CEREC improved, I started doing a little bit more on the restorative side. So I don't do the final restorative dentistry. That's not what, I'm a surgeon. But I do when a patient comes in, let's say, they came in on Monday morning having broken out off tooth number 8 at the CEJ over the weekend. We're taking out the tooth, we're placing the implant using guided surgery, and then we're able to place an immediate provisional, single-piece screw-retained provisional made with CEREC and deliver that at the time of implant placement, which is usually a couple of days later. And so we're doing custom provisionals in cases like that. I'm creating custom healing abutments to help contour the tissues when I place implants. So rather than just putting a round healing abutment in place, especially in the anterior, if we can't do a provisional, we're doing custom healing abutments that really help form and shape and support the soft tissue. And then, of course, I have some of my referrals who are, basically prosthodontists, and all they want is a healing abutment, and then my job is done. But I have others who want me to put an abutment on the implant for them. And so for those dentists, we're actually creating custom abutments for them with CEREC, and then letting them do the final restoration. So I'm using all the capabilities of both the CAD-CAM and the cone beam together. And then, of course, when it comes to the surgical guide, what we do is we upload our data to CCAT in Germany, which is part of Sirona that actually creates the surgical guides. And we're getting back an STL file, a stereolithographic file, generally within 48 hours when we upload the data for our implant plans. And so I'm able to then produce the surgical guide and do the surgery just a couple days after the patient comes in for consultation if we need to. And I have a couple different printers that I'm working with. The first one I got is the Cell Robox, which was a $1,500 printer that I got just sort of as an experiment to see the kind of quality I would get from it. I was actually pretty happy with the guides that it was producing, but we've sort of upgraded now to the Form Labs. They have a new Form 2 printer that actually, rather than printing from a spool of polylactic acid material, actually uses a resin, and it's a little more sophisticated type 3D printer, a little bit more accurate. So that's what we're starting to use now for printing the surgical guides. These guides take about 3 to 4 hours to print. So generally what I do is I'll get the STL file or files in the morning, and then I'll batch print in the evening. So before I leave the office, I'll download the STL files for the surgical guides into the printer software, and then hit print as I leave the office. And when I get in the morning, then the guides are printed, and then all we have to do is finish them off, which takes about maybe 5 to 10 minutes a piece before the case. So that's sort of our workflow. And it's been working well for us. We've got all the technology in the office to be able to have the patients come in, accurately plan their implants, print their surgical guides, and then either a provisional restoration or a custom healing abutment when we place the implant. So I think it's this is the way that the direction that implant dentistry is going. I mean, definitely all of dentistry is going digital. The analog technology that we've had for the last 2,000 years is finally being replaced by digital. And I think it's great because not only is it a easier workflow, but it's also more accurate. You don't get the distortions that you get with dental materials with PVS and alginate and stone and plaster and plastics, and everything changes dimension as it cures. And with digital technology, you have a much greater accuracy because you're not working with all these different materials and hoping that the expansion of one will counteract the reduction of the other one, and vice versa.
Yeah, and it's an ever-changing world, and it's always good to be caught up with that now. So if you've got a patient that you've done a scan on and you realize that you need more bone there, and I know that means a lot of things. Could be the atrophic mandible, could be sinus pneumatized down. What's your favorite type of grafting to do? And are you doing sinus lifts? Are you doing the lateral sinus or from the socket site? Are you doing ridge splits, or are you doing some of these reverse cutting expansion drills? Why don't you tell me how you make more bone in your practice, and what's your favorite methodology as far as what works best in your hands for kind of bone expansion and augmentation?
Well, I've got a lot of tools at my disposal. I don't do everything the same way. I've got from my training. I basically do the whole gamut, whatever the patient needs. So, for example, if the patient has a little bit of an atrophic ridge in the maxilla and some pneumatization of the sinus, if they just need a couple millimeters, let's say, we want to place an 11 millimeter implant and they've got about 8 millimeters of bone. In the case like that, we'll do an indirect sinus lift. So we'll actually do, the traditional Summers technique. Now, I've actually come up with a modification, a way to do that more accurately and efficiently using surgical guides. But we'll just do your traditional indirect sinus lift. Now, if the patient needs more bone, let's say they're missing number 2, 3, and 4, and they've got a greatly pneumatized sinus, and they only have about 5-6 millimeters worth of bone, and they really need more significant augmentation, then of course we're doing the lateral access full open sinus lift. And what I like to use for that is the piezotome. And so if those who are not familiar with it, basically what the piezotome is an ultrasonic cutting instrument. So you put some type of saw or bone cutting attachment on it, and just like with a Cavitron, essentially what it does is it will cut through the bone at a frequency that's very efficient, but when it contacts soft tissue, it does not damage the soft tissue. So it allows you to cut through the lateral wall of the sinus without damaging the sinus membrane, which, as you know, can be kind of thin in some patients. Once you've taken your little window out, you can actually then use a different tip on the piezotome to lift the membrane away from the sinus wall and from the floor of the sinus without damaging it. Now, when I first started hearing about sinus lifts, everyone said, "Oh, you can't tear the membrane. If there's any tear or hole in the membrane, it's disaster." I think we know now that that's kind of not the case. That you can have small tears in the membrane, you can have small perforations, because in a healthy membrane, sometimes it's very hard to lift. It doesn't separate easily, and sometimes you do get small tears. And so what I'll do is I always reinforce the kind of the roof of my sinus lift with a collagen membrane, and then I graft with freeze-dried particulate corticocancellous. And I like to use the Symbiose graft that we get from Dentsply Sirona. And it's a corticocancellous mineralized graft, and we'll pack that in. And usually a sinus takes anywhere from 2 to 3.5 cc's of bone. So we'll pack the bone into the sinus, and then of course replace the lateral wall, and then go ahead and close it up. For sinus lifts, I mean, they're pretty successful, and so I don't use anything generally like BMP or PRP or anything like that for sinus lifts, because on their own they're generally pretty highly successful, and you get a great result. For a ridge augmentation, if you want to build up the ridge, building up height is very difficult. Building width is much easier. And most patients that we see have either a ridge width deficiency or they have both a height and a width deficiency. And we used to just basically do an on-lay bone graft. We harvest some bone from the ramus and graft it to the site to build up the height and the width of the ridge. And what I realized was that what we're doing is we're taking essentially cortical bone from the ramus area that we've devitalized, and we're taking it to the recipient site in the maxilla or the mandible that we've prepped a little bit, by perforating the cortex, et cetera. But essentially, we're putting cortical bone on top of cortical bone and putting the periosteum back and hoping that it heals. And sometimes we're kind of sadly disappointed in the results that we get. With a narrow ridge, I've become a huge advocate of ridge splitting. And again, I use my piezotome for splitting the ridge because I can split the ridge pretty deeply and make sure that if I'm coming close to the mandibular nerve or the mental foramen area, that I'm not going to affect the nerve. So we'll split the ridge with the piezotome and then use a splitting osteotome to widen the ridge. And then we'll place the implants into the widened ridge using the surgical guide. And so what we'll do is, let's say the ridge is a little bit narrow, but it's when we plan our implants based on the final prosthesis, the deficiency is more to the buccal than it is to the lingual side. And so we know when we do the ridge split, we're going to expand the ridge more to the buccal than we do to the lingual. Then we put the surgical guide in, we place the implants, and the implants go in based on the surgical plan and using the guided surgery guide. And then, so the implants go in very accurately, and then we do bone grafting with freeze-dried particulate with the Symbiose around the implants, put the cover screws on, cover that with resorbable membrane such as the Symbiose collagen membrane, and then we'll close the wound primarily in order to allow that to heal. For ridge preservation after extractions or for bigger grafts, a lot of times I'll use, in addition to the particulate bone, I'll cover that with a Teflon membrane. So the polytetrafluoroethylene membrane is, I think, a really nice membrane. It protects the graft well. And if it should become exposed intraorally, if you get a little wound dehiscence, it's generally not a big deal. You just have the patient keep it clean with a little chlorhexidine rinse on a Q-tip, and generally we can maintain the membrane in place for 6 weeks, 8 weeks, 10 weeks before we take it out. And then we've got a nice layer of granulation tissue over our graft, which will then epithelialize in any areas where there was deficiency. So those techniques work real well. I do some on-lay grafts from time to time when we've got a lot of deficiency, let's say in the posterior mandible, although I've been doing a lot more just using freeze-dried particulate, using the Symbiose graft along with a product called Amnio Matrix or Amnio MTM. And what it is an amniotic membrane-derived essentially growth factor mixture that's got a lot of growth factors, it's got prostaglandins, it's got stem cells, and we're finding that unlike bone morphogenic protein, which creates a huge inflammatory response afterwards and causes the patient a lot of pain and swelling, this Amnio MTM is actually anti-inflammatory and immunoprotective, and we're seeing very nice, healthy tissue in the areas that we grafted. as well as enhanced wound healing and increased patient comfort when we're using that in conjunction with our bone graft. So there's a lot of great products out there that have evolved over the last, let's say, 20 years as we've gotten more knowledge of bone physiology and some of the growth factors that are enabling us to really accomplish a lot more successful bone grafts than we used to, and in a lot more situations.
Yeah, that's great. It's not like you've just got, one trick now. It's like you've got a trick for every part of the mouth and every part of deficiency. So that really opens up, your possibilities for, restoring implants and restoring teeth. So that's
exactly.
That's really good.
You've got to be able to modify. You've got to be able to modify your technique based on the situation, because not every case is the same. You got to have a few tricks up your sleeve.
Yeah. And the cone beam allows you to see that ahead of time and plan for that. And so you're really doing the surgery in your mind, and then you're doing it on the patient. So it's kind of, you've got that perfected down. So that's really good.
Exactly. It's kind of like when you're building a house, you don't just get a bunch of buddies together with some wood and a couple 6-packs and start hammering some nails and seeing what develops. You start with a very detailed plan, and you've had your architect do a very detailed rendering of how the house is going to look and where the electrical is going to go, where the plumbing is going to go. You've had your geologic survey, so you know what the land is like and you know what the foundation is going to be like. And so you've got all the information up front, and that then makes the surgery much easier, much more efficient, and much more successful.
Yeah, that's great. Now, we're about out of time here, and I'm gonna have to have you back on for another episode, because I only got through like half of my questions with you. You're just a wealth of knowledge. So We'll meet up again maybe next month if you've got some time and finish up some of these other questions. But I want to leave the listeners with a couple specifics, because I know you've got a very good website for your oralsurgery.com, onlineoralsurgery.com, and you've also do some speaking. So if somebody wants to get a hold of you or see you out speaking or become a part of this online oralsurgery.com, give them a real quick and dirty, what's on your website, how do they get a hold of it, how do they log on, what's on there, and then how can they see you out speaking? Because I'm sure, myself included, I would love to learn. I'd love to see your videos. I would love to catch you out on the circuit somewhere. So give us some of that information so that, we can all keep up with you.
Okay. Well, the best place to go to is onlineoralsurgery.com. And on the website, we've got about 25 hours so far of continuing education videos on all kinds of subjects, from basic dental alveolar surgery, medical considerations, how to manage emergencies, implants, bone grafting, and we're expanding the offerings all the time. In fact, before I got on the phone with you, I'm working on a course on how do you set up your office to do dental implants, because most general dentists who are getting into implants have no idea about sterile technique and how do you drape the patient, what do you sterilize, what needs to be clean, what needs to be sterile, etc. So that's one thing that we're working on right now, as well as some videos on how to utilize your staff in your practice and have your team make you be more efficient in surgery, because those are real important things that you learn as a surgeon. So we've got all the videos on the website. In addition, we have some links. One is to see where I'm lecturing throughout the year, and it's kind of frightening when I look at my schedule for the year. I think I've got, there's 52 weeks out of the year, and I think I'm on the road about 42 weeks this year in 2017, so it's going to be kind of crazy. But it should have a listing, at least for the next few months in advance, where I'm going to be speaking. So that's a link on the website. The other is a link to the courses that we offer. We're offering some live courses on essentials of implantology and guided implant surgery, which we've gotten really great feedback on the doctors who have taken the course. So there'll be information on that, and that's actually links on our homepage. In addition, we have a discussion forum. So if you have a question, you can either you can go on the discussion forum and put it out to the members at large. How would you handle this situation? What do you recommend? I'm always moderating all the forums, so I'm usually chiming in on everything. Or there's a link to just email me directly. So you can, and my email is really easy to remember. It's just j@onlineoralsurgery.com. So you can get a hold of me that way. And then, of course, to get access to all this, you have to be registered on the website. So we've got a 30-day free trial membership, which gets you into about 10% of the content. So we've got not only the videos, but we also have practice forms that you can use for some of the surgical procedures, consents, post-op instructions, pre-op instructions. We've got articles of interest and the handouts from lectures, etc. And then most people who have done the trial then will register for full access, which is unlimited access to pretty much everything on the site 24/7, and that is either $50 a month or $4.95 per year, which is a much better deal. The other thing is that we have recently received AGD accreditation for PACE certification, so we will be soon awarding AGD credit, CE credit for the courses that you take on online oral surgery. So we've got a lot going on.
That is a lot going on, and I'm glad you went and got certified, because I think a lot of people unfortunately need that nudge to get that training, but when they realize once they get it, they realize, man, I should have been doing this months ago. So it's always good to give them the credit, because they should have been doing it anyway. But some people just got to get that credit, and they don't justify the money until they do. So I think that's great. But I know just talking to you that the wealth of information is just probably awesome. And so I'm gonna encourage everyone to join up at least for that free 30-day trial. And then, like you said, that's a way to kick the tires, and if you like it, just go for it. Exactly.
And the feedback that we get from the subscribers is just absolutely incredible. They're just the amount of knowledge that they get in a format that they're not used to. I mean, the video format works really well because it's not just showing you a PowerPoint presentation, but you're actually seeing video that we shoot in the office when we do surgery from 2 or 3 different angles and editing the video. So you really get a clear view of what we're doing. Everything is explained really well. And so most people who've watched the videos and are what really feel that it's been a huge benefit to their practices and to their patients, which is really what the bottom line is.
Yeah, it is. I mean, that's what we're in this for. It's not just to, like you said, not to stroke the egos. It's just to provide better care. And
exactly.
and if you approach it from that approach and that philosophy, you're going to get good. And hopefully you're using that good for to pass on to treat patients. So.
Exactly. That's why we're in it. I mean, we need to make a living and take care of our families, but really the reason we went into dentistry was to take care of people. And so we want to make sure that everything we do, the patient comes first, and that we're always doing what's best for them. And big part of that is having knowledge, but also always expanding your knowledge because things change. And it's always good to learn new ways of doing things and to expand your horizons to be able to bring more types of care to your patient.
Well, I'm gonna call it quits today, Jay. I appreciate your time. Loved interviewing you today, and I'm sure my listeners are going to get a wealth of information. So I encourage everyone to go see Jay speak, or go to onlineoralsurgery.com and sign up. I know I'm definitely going to do that, and maybe I'll touch base with you here next month or the month after, and we can follow up on the rest of those topics that we didn't get to.
Sounds good.
All right. Well, thank you. Have a great afternoon.
You too.